Thank you, Professor Hatta, for that kind introduction. And good evening, everybody, and thank you to Canon for the invitation. It is truly a great honor to be here because there are so many famous people, our moderating panel, and also in the audience, so I hope I do this talk some good justice. I'm going to talk to you about high-frequency ultrasound, how high we have come, and what applications you can use it for. So if you're using a Canon system, you'll be spoiled because you have a choice of so many high-frequency transducers, in particular the 24 megahertz probe, which have very high-resolution images and good penetration down to 2 centimeters, which is also complemented with the 22 megahertz hockey stick, very useful for those difficult corners and areas, particularly for the MSK and head and neck work, which you have to go around corners quite a lot. But the workhorse is the 18 megahertz probe, a very versatile probe with a wide bandwidth, good image quality, and good penetration down to 6 or 7 centimeters, and that is really our workhorse probe as well. But the icing on the cake is also the advanced applications are available on most of these probes, and certainly with the 18 megahertz probe, you've got all these technologies available at your hands. So let's have a look at some examples. This is an 18 megahertz probe at the top and 24 megahertz probe at the bottom, and you can see this is a cystic lesion, but you get much better clarity with the 24 megahertz probe, and what you can actually see is a tract leading up to the cutaneous surface. So with the 24 megahertz probe, you're very confident that this is just a sebaceous cyst, an epidermoid cyst, which you don't have to do anything more. Of course, with the near field, the 24 megahertz probe, you turn on SMI, microvascular imaging, and you can actually see the vasovasorum beautifully of this skin ulcer, showing that it is infected skin ulcer on its own. Where SMI comes into its own is work with arthritis, and this is a patient with rheumatoid arthritis. And you can see the great detail that you can get with this 24 megahertz probe. This is the head of the metacarpal, and you can see an erosion and marked vascularity and a synovitis with SMI, much better shown than with power Doppler on its own. If you turn to other organs, you get a good mixture of densities. You can see this is a benign appearing but big thyroid lesion. You can see the multiple densities with calcification and cysts very clearly. And in this case, a benign appearing nodule, but you only appreciate this area with a 24 megahertz probe, a subtle hypoacusionicity, which we followed up, and it cleared up after 3 months, suggesting that there was an area of focal thyroiditis. But here is where it comes into own, again, the 24 megahertz probe in breast work. Now, the images look big, but actually, if you look at the scale, this is actually just 1 centimeter. So this lesion I'm pointing out to you here is only 4 millimeters. And this, what you can also see with SMI is clear vascular flow, so it's a true solid lesion, but you can follow the duct that it is in. So very clearly, you know that this is going to be an intraductal lesion, and this turned out to be a breast papilloma. So I'd like to just spend some time telling you about how you can combine this high-frequency imaging with fusion technology and how this has really helped us with our clinical work in sorting out difficult breast lesions in patients with breast cancer. So with these probes, you can attach a sensor to any of these probes to tell it where it is in space, and you have a magnet which throws on an electromagnetic field, and with that, you can actually fuse an ultrasound image with an MRI image, and I'm going to show you in a little while. So this is our setup at our center. We actually have the magnet on a stand because we can then move it around the patient either to the right breast or the left breast itself. And one key thing is that you have to review your MRI images well and download the best sequences. The setting up of the fusion system is very straightforward, and the synchronization is also very easy. But bear in mind, these are cases that come to us which already have a difficulty, which we can't see a lesion without ultrasound on its own, and they're asking us to perform a breast ultrasound MRI fusion to see what we can see. I like to test myself a little bit by performing an ultrasound first without fusion. And we synchronize with the nipple, and in most cases where we don't like too many lesions in the breast, actually the more lesions you have, the better your synchronization gets. Of course, there's a discrepancy between the prone image on an MRI and supine image of an ultrasound, so it's not 100%. You have to use a little bit of cognitive fusion and use your assessment as a radiologist or a sonographer on its own. So let me show you what you can do. So this is a fused image. You can see very helpfully a breast cancer on the MRI. You can see it matches the lesion on the ultrasound. But what I was asked to find, if you look, there is a tiny enhancing lesion just further up in that breast itself. And actually, with fusion, it then fused to this image here, which may have been difficult to know that you were looking at the right thing. And this, when we biopsied down, just turned out to be a lymph node. But that was certainly throwing up enhancement on the MRI scan itself. Here's a case of a lobular cancer, and we know they can look very much like glandular tissue. So when I put the fusion on, I was expecting a big lesion, but actually you see a non-mass lesion. It looks like fibroglandular tissue when you fuse it. And of course, when I just biopsy this area here, it all turned out to be lobular cancer. So very useful to have this fusion technology to give you confidence. Again, a problem solver. Patient with a breast cancer, ring-enhancing lesion near the nipple, and actually it just fused to this simple cyst, so we could have let it go very, very quickly. But a couple of examples where it has proved really helpful. In this patient with a 30-year-old lady with blood nipple discharge and a subtle enhancement area, and a radiant ultrasound has been looked without fusion but couldn't see a lesion. So as the MRI place is in the left breast, and that's that subtle enhancing lesion as we go through it. And with fusions, you could see the lesion on its own very, very easily. It's a dilated duct here, and when we biopsy that, there was an intraductal papilloma sitting within this dilated duct. So before fusion, you really couldn't see it, but this honed your eye in, and you could appreciate where the abnormality was. Here's a slightly complex case, again, just to illustrate how useful it has been. In a patient with a proven malignancy in the right lower inner quadrant, a benign lesion in the upper outer quadrant, and another lesion which the MDT were not satisfied that we had sorted out. So what you're going to see is the benign lesion, which was biopsied and clipped. This was the cancer, which we knew and were proven. But what they wanted to sort out was, an astute colleague of mine noticed, actually, there's something right at the back of the breastplate, high up, a difficult area to assess. And actually, this is the third ultrasound now. Nobody could find a lesion up there at all. And when I put on ultrasound fusion with the MRI on its own, you can actually see a subtle change at the edge of the breastplate from glandular tissue. And when you turn it around, actually, there is an area of distortion, and the SMI helps you become more confident that, yes, there is actually a lesion sitting there. And this is one of the few cases where I needed to have the fusion to perform a biopsy, because most of the time, once you've seen it, you can turn off your fusion and you can biopsy the lesion quite happily. And you can see my needle gap here using fusion to make sure I biopsy that area. And that was a second cancer. So we saved her an operation that she needed a mastectomy rather than just a wide local excision. So this was just a check mammogram. We clipped everything. This was the benign lesion. And the lesion that I clipped and biopsied was right back where we expected to find it on the MRI scan. So our question was, can it help with the second look ultrasound scans, with this technology and high resolution ultrasound? Then in our 73 lesions to date and cases that we've looked at, we could see 21 lesions without fusion, and 46 cases we needed ultrasound fusion to see a lesion. And in 5 cases where we couldn't see it, they went on to have an MRI-guided biopsy. In 4 patients, there was also a choice for them to actually just have an MRI-guided biopsy on its own. So what our data showed was that out of the 9 MRI-guided biopsies, 7 were benign and 2 were malignant, but we didn't get an opportunity to biopsy these because it was patient's choice to have an MRI-guided biopsy. But the crux is that we saved a MRI-guided biopsy in 44 patients, so more than half we're saving them a difficult procedure and lengthy procedure. So really helpful in our clinical practice. And I don't have time to go through this, but this is our MDT tree. Basically, these are decisions made by radiologists, breast surgeons, and oncologists, reviewing the MRI scan and the whole clinical status, and we select patients for an ultrasound MRI fusion. And if we see something, great. But if there's no abnormality, then we give them the choice of an MRI-guided biopsy. But one key thing is we make sure that the biopsy is concordant with the MRI and the ultrasound findings. So in our last few minutes, I'd just like to tell you a little bit about what's the future with high-resolution ultrasound and how high can we go on 2 studies that we have ongoing at the moment. One is a super-resolution ultrasound for testicular patients with hypogonadism, and another one with intraoperative brain ultrasound. So what you see are these patients are coming to us for infertility, and they have very small testes. And these are raw data, so the testes are very small. This is only 2 centimeters, so these testes are maximum 1.5 centimeters in length. This is raw data of microbubbles on its own. And you can see, after 3 months treatment on this patient with gonadotrophins, you can actually see more microbubbles, and the flow within the testis itself is much more abundant. My clever colleagues in the bioengineering group can perform super-resolution ultrasound algorithms, working with this raw data obtained on a clinical system. And they can plot trees, and you can measure vessel density, vessel velocities, vessel area. So a lot of parameters now, functionally, that we can obtain very, very well clinically. And this is just an example of what you can get in the patient here. There's a control patient getting testosterone only. So, and this with gonadotrophins, you can see the increase in vessel density on its own. And it's the first time that we've got a biomarker now, which is actually better than sperm production. So a very useful tool for andrologists in the coming years. And this is just our data, scanning patients at baseline, 3 months and 6 months. Again, one key thing, the most significant was the vessel density going from baseline, and you can see difference compared to the controls on its own. And the last area, which we have some interest in, as you can see, once you do an intraoperative ultrasound, this is, of course, with a lower frequency probe. This is a glioma, but you can see the images once you are on the brain itself looks like an MRI image, in fact, even better. And what you can see here is with a 22 megahertz probe, you can actually see much better image quality. You can perform elastography on it, but the SMI images are really exquisite. And once you give contrast, then you can measure parameters in the brain and in the lesion itself, and also perform some SMI and super resolution on it. And what we have shown in some early data shows that actually these patients have better resection margins and hence better outcomes from their operations once we perform this intraoperatively. So in conclusion, high-frequency probes with superb image resolution allows more accurate diagnoses. Advanced applications available with the latest probes increases diagnostic capabilities, and these advancing technologies opens up a myriad of clinical applications. Of course, with all this to hand, really, I'd like to thank the groups, testicular group and brain group, who actually do a lot of also the post-processing and research that carries out in our institution. But with all these applications, we are really dependent on the operator working and utilizing it to the best benefit of patients. So with that, thank you very much for your attention.